speaker is none other than Dr. Chowdhury Hafiz Ahsan. Before the start of the lecture, I'd like to request Professor Atahar Ali sir to say some words regarding Chowdhury Hafiz Ahsan sir, and then we start the session. Atahar Ali sir.
Thank you, Tushar, for inviting me. After a long time, this is the ECG Study Groups program, and we are lucky to have our renowned speaker, Chowdhury Hafizul Hasan. He does not need any introduction, but still, some of the newcomers. This is Chowdhury Hafizul Hasan, very renowned and a very well-renowned presenter. We always enjoy his presentation, and today we are going to enjoy his presentation again. And he works in, he's a professor of medicine, Nevada School of Medicine, that is the Las Vegas. So this is Chowdhury Hafizul Hasan. I am inviting you to present your presentation. Chowdhury Hafizul Hasan.
Okay. Thank you, Atahar Bhai, for the kind introduction. And I must tell you that I'm really encouraged that there are 88 people in this webinar. This is really good. I think, it just hit 90. Rafique Bhai would have been really happy. But he called me, he apologized because he's in a tour with his brother-in-law, who is also an EP doctor, Mohsin, and they are having fun while we are doing this EKG session. So I don't need to give this really learned group about the ECG definition of the STEMI. But I tell you one thing, though, that it is not emphasized enough that EKG is the tracing and it is the ST elevation is an observation. We need to interpret the second part, which is even more important, which is MI, and that is clinical. That is clinical. So any ST elevation interpretation should be in the context of an MI presentation to call it a full-fledged STEMI. So EKG is not pathognomonic of STEMI. We need to entertain many things. And it is equally important that we do understand the EKG presentation when we talk about infarct-related artery. There are many reasons for that, and it has important clinical and practical implications. So if you look at the septal is V1, V2, anterior is V3, V4, lateral is V5, V6, and then anterolateral whole thing is V3, V6, extensive anterior, inferior is 2, 3 AVF. We'll talk about how to differentiate with RCA and CERT, and then lead 1 and AVL, and the posterior MI, which is really an important issue, and we'll show some case examples. So these are the things that we need to keep an eye on about localizing the EKGs. For example, what will be the culprit artery here, and where is the lesion? Anyone to chime in?
LED, Hafiz Bhai?
Yeah, so looks like the lead 1 to lead 6. And this is like extensive anterior, correct? We don't see in lead 1 and AVL. So I don't know, Wadud, okay to say that this is extensive anterior? Most likely a proximal LAD.
Yeah. There is
and this patient, if you auscultate and there is an S3, this could be an early sign of LV failure. So you need to be very careful when we are taking to the cath lab. And also, we now have plenty of data that the more the ST elevation, the more likely that the patient may have an impending VT arrest. So we need to really move fast. How about this one? Lead 2, 3 AVF. And then if you look at lead 1 AVL, ST depression, the lead 2-3 AVF, that looks like almost similar magnitude in lead 2-3 AVF, but there is V5 also and V6. Most likely a left circumflex can be a dominant circumflex. Now, left bundle is always a problem. And what about this one? That 2-3 AVF doesn't look like any significant changes. However, ST depression in the V5, V1, V2, and T upright. This raises isolated posterior. Isolated posterior is not common, usually associated with inferior, but when it is not usually associated with inferior, we call it isolated posterior. And in that case, couple of things important. It could be RV involvement and doing lead VR, right-sided lead. Normally we don't need it, but isolated posterior may help. And RV involvement and hypotension has significant prognostic implications.
Hafiz bhai,
Yeah.
how about the V5 and V6?
There is some, but you need, it could be a very involvement of the posterolateral branch,
Okay,
maybe an RCA or maybe a dominant circ. We can't tell.
thank you.
So here is another EKG, patient coming with chest pain, not sure. Sometimes if the pain is severe, clinically looking like STEMI, then we don't need to pay too much attention of the EKG. However, I understand when you give some poisonous drug like thrombolytics, we need to be very careful about convincing ourselves that it is indeed an STEMI. Repeat EKG, that may help, right? So every 5 minutes repeat EKG sometimes can be of help as well, and you can convince yourself. Left bundle and paced rhythm, I'm not going to talk too much about it because a new left bundle, but clinical context is important. Somebody coming with toe pain or below umbilicus belly pain and an EKG is done, then this is not MI. Clinical context is important. You can invoke the Garbosa criteria, but the more you add in about the 1, 2, or 3 criteria, the sensitivity with one will be higher than specificity when you see all 3. Paced rhythm, very difficult. Bedside ultrasound may help, may not help, because many of the paced rhythm patients may have wall motion abnormality or pre-existing LV dysfunction, particularly those who had previous CABG. I think then it is a clinical call. LVH, we should not be fooled by the LVH with the STEMI. Sometimes that can mimic ST elevation, and clinical presentation is very key. Acute pericarditis is important to recognize, and particularly in a younger patient, when it is not behaving like a clinical MI, then patient is having fever. Sometimes you get clues about pericardial rub, we can listen. But what is helpful, I have seen that if it is a bedside ultrasound showing hyperdynamic LV or normal LV, no wall motion, because transmural MI, really, the LV wall motion gives you a clue. It is the subendocardial ischemia, non-STEMI, where subendocardial ischemia without transmural MI can give you normal wall motion. So in that case, it may not be that helpful. Myocarditis, yeah. Myocarditis can be focal myocarditis or focal perimyocarditis, give you localized pericarditis. Very common after CABG. Focal, the regional pericarditis, giving you the sort of suspicion whether there is any graft down. But you need to be very careful before you take this patient to the cath lab again. This is another example of focal perimyocarditis. So early repolarization is very common in African American, and now there is more data that early repol can be associated with some arrhythmias, but generally speaking, these are very benign and no issues. So the EKG can be a real problem with stress cardiomyopathy. The stress cardiomyopathy, where there is really no role for thrombolytics, very difficult to differentiate. And I give you a little cautionary note, because clinical context is important. Like somebody, young female with recent delivery of baby or pregnancy and coronary dissection or aortic dissection with EKG changes, you need to be careful about giving lytics. Similarly, elderly patients or patients with emotional stress, and you have a bedside echo showing not so good correlation with the ST elevation and the apical ballooning, then before you give lytics, you need to be careful and suspect this, and then do the angiogram before you do anything else. And this is the problem with the stress cardiomyopathy. And that's why it is very important that we as a group should actually promote bedside ultrasound to get an idea about what is going on with the LV function and whether there is any morphologic sign of apical ballooning or, for that matter, stress cardiomyopathy. This is very, and we published this in by echo, that echo can be helpful. And in COVID time, we actually avoided many patients for going to the cath lab. Typically these patients have troponin like 2,000, 4,000 in the 5th generation, or 2 or 4 in the 4th generation troponin assay. And you don't see 50,000 or 50 or 100 in the 4th generation, because when you see that massive troponin, it is usually not stress cardiomyopathy. It is usually only 2 conditions, the MI or significant myocarditis. So troponin is not a binary thing. It is the magnitude of troponin rise also indicate where is the problem. And you need to look at the EKG, look at the patient, look at the echo, and then decide what to do. Patient with old cabbage and this kind of EKG and niggly chest pain, we really need to think about LV aneurysm, which can give you persistent LV aneurysmal picture in the EKG and very big pathological Q wave. And please do not give lytics right away, because it can be fooled. Pulmonary embolism, I would tell you not to worry about ST elevation. Pulmonary embolism giving ST elevation is extremely rare, but sinus tachycardia and hypoxia, we should have some idea, and bedside echo can be helpful. Rarely it can give you right bundle, and also the precordial V1, V2 ST elevation. However, if you do bedside echo, it can be really helpful. Another thing helpful is the patient has disproportionate hypoxia. This kind of ST elevation in pulmonary embolism, it is not peripheral emboli, it's the proximal big vessel pulmonary emboli, and you see massive hypoxia. So this is like a very rapid fire general overview, and I just go through some cases now. This is ST elevation post ventricular arrest, and this is really important that we go fully prepared. For example, for the interventional guys, it is very important to go with the guide after the right coronary visualization, and don't waste your time. Okay, I have this issue now. Okay, so at least it's moving. So right coronary, and then we just do the, so I usually like to do the echo, but this is not an interventional lecture. So we can go right away for the case discussion that what happened, LAD opened up, and then this patient has this evolution of the EKG changes. And it is important to remember this EKG, because patient goes home, 3 days later comes back to the emergency room with this EKG. We should be careful not to call a STEMI. It can be the tail end of the troponin, and it can be the previous EKG evolved into this. So old EKG clinical context is also important. So this is another patient with that LAD that we intervened. So this is 55-year-old chest pain. What to do? So I tell my fellows that evaluate this patient quickly. Is the patient has any comorbidities, on any medications? So 3 questions we need to ask the patients. Why you are here? Have you been here? Did you have any problems before? It's like Leo Tolstoy asking 3 questions. Who is the most important person? What is the most important time? And what to do best? So the most important time is now. Most important person is not the Google search or Facebook. It is the person next to you. And what is the most important thing? The work at hand. But for interventionalists, most important thing, why you are here, chest pain. Is it associated with any nasty complications, such as hypotension, shock, anything, any problem before? And do you have any procedure done before? Once we sort out that, and there is no complications, you can then think about and convince yourself that chest pain is typical of MI. EKG looks like MI. You can give lytics and pharmacoinvasive strategy, or access to the cath lab, go to the cath lab. Similar thing, patient has typical chest pain, typical EKG, life is easy, give lytics and pharmacoinvasive strategy, or go to the cath lab and take the patients, load the patients with full pharmacotherapy. And this can happen in the recovery room after reperfusion. This is typical of reperfusion arrhythmia. Just don't do anything. This is not VT, and then patient is fine. The heart rate is around 90, 100, and then patient will be okay. So transmural MI will give you wall motion, will show you transmural ST segment elevation, and later on will evolve into QMI. But we don't wait for Q wave. So when you are dealing with someone in the beginning, if there is Q or not Q, that is not going to be the deciding factor about what you do with this patient. However, presence of Q tells you something. So pay attention to that. And vast majority of the patients will not have any ST elevations or Q wave if you are dealing with non-ST elevations MI. And many of the non-ST elevations MI can be high risk, such as Wallen syndrome, right? This is typical biphasic. But remember, in LVH, sometimes when they go into treadmill, double product, meaning systolic blood pressure times heart rate goes high, there is demand-supply mismatch. You may see some T-wave changes, not necessarily meaning high-grade stenosis, false positive treadmill. But in the emergency room or in your hospital coming to this typical 10 out of 10 chest pain and this evolving EKG, this is typical of proximal ostial LAD. Very high-risk patients. This patient should never go to the treadmill test. And I give you this scenario after talking all these, this patient was in neurosurgical ICU. Troponin came 4,000, EKG showing ST elevations in the precordial lead, and some T-wave inversions you can also see. What to do next? Should we think that this is typical of LAD ischemia? Not LAD ischemia. Anterowall STEMI should give to think about revascularization. Number 4, SES, start DAPT, heparin, get echo. And number E, I'm not a cardiologist, go to hell. Any suggestion?
It's a cerebral T inversion.
Was that?
Cerebral T inversion.
Cerebral T inversion. Very good. So this is not STEMI. And patient, and God gives you clue, right? God tells you that patient is in neurosurgical ICU. Find out what's going on. Clinical context. That is very important. And we cannot do harm because we are not sure. Oh, at least give aspirin, at least give heparin. No, because you need to recognize this. A D Winter sign, which is the very acute angle STA changes. If the clinical context is right, this is LAD. It is very important to recognize that and see how this ST changes. And if the presentation is right, I would not say that you give lytics, because I'll talk about that later, because many of them may have some TIMI3 flow, but high-grade stenosis presenting like this, it is better to think about revascularization than give lytics. So proximal LAD is a very important issue to think about, because if you look at any studies, LAD involvement in the equation of taking care of acute coronary syndrome, left main and LAD has the highest morbidity and mortality. So with having said that, everybody will recognize in this, by the way, the number has gone up to more than 100. Tushar, thank you so much. ST elevations, and this is LAD. And this is important to recognize, right? And why I'm saying this? Because if you look at this, high risk non-STEMI versus STEMI, if you leave them with medical therapy, both have bad outcome over 7-8 years. So medical therapy is not a good option. Medical therapy is not a good option. Many non-invasive cardiologists in Bangladesh trying to say that it doesn't matter, in non-STEMI is okay. But we need to identify who in that group is high risk. Their morbidity and mortality is really high. STEMI, we all know, we jump on, but I'm telling you, when you look at the STEMI and non-STEMI and revascularized, you really make a difference in their outcome over the years. Very early on, if you look at the within 30 days, the STEMI is higher, but non-STEMI high risk, they catch up and their natural history becomes same. So it is very important. And this is the next slide, is about the dope to balloon time. Earlier is better, definitely. Earlier is better, but we have logistic challenges. We may not be able to run the cath lab all the time. So we opt for non-invasive therapy, lytics therapy, but we have to go for the pharmacoinvasive and transfer the patients out as soon as possible for the primary PCI hospital. There may be logistic challenges and a lot of argument, but I'm talking about what is ideal. So STEMI and STEMI mimics. Let's go through a series of EKG examples. This is really easy to figure out. Anterior, maybe anterolateral with lead 1 and AVL as well. this is STEMI picture or not? Any thought?
Extensive anterior STEMI.
No. Look at carefully 2-3 AVF. And then
Yeah.
look at the lead AVR.
Previous one.
So
Previous
it's
one.
pericarditis. STEMI or no STEMI?
But this is
I like to
STME.
say HTME mimics, looks like.
Yes. So I think we should learn ourselves and make our brainstem get used to this. Yes, there is ST elevation. What is the clinical picture? 27-year-old with fever, pericarditis. Thank you. What is this? The patient with left bundle coming with COPD exacerbation. And there is alternative reason, old EKG possible. So ST elevation does not look like ST elevation MI, and the clinical picture does not fit in. This is ST elevation is there. Yes.
Sir, just
Yeah.
have a question. Many a times when we see this ECG, if we and there are some erroneously raised high sensitive tropi, so that
Yes.
creates the confusion.
Hello?
Although the clinical context doesn't match, but when we find the high sensitive tropi level raised with LVV pattern ECG, then it creates
Yeah.
the confusion and all the
Yes.
features.
So think about this. Very good question. So let me walk you through. If the troponin comes in, and if this is left bundle and ST elevations, new left bundle, because you don't know the previous EKG, what is the infarct-related artery will be?
Sir, it is
Definitely
highly
LAD.
LAD,
Sorry.
and it is usually prox LAD, correct? Prox LAD, you can do a bedside
Before S1.
echo,
Yeah.
and then you can look at the clinical context. COPD hypoxia can give you troponin. If it is prox LAD troponin, that will be thousands, not small troponin. So you have time, little bit, but you have the imaging to also help you. Because if you have an alternative explanation to explain the small troponin, then you are good. Similarly, this patient also can be 55-year-old diabetic hypertension. He is also entitled to have flu-related pericarditis. But if it is 27-year-old, you will be calling pericarditis, and 55-year-old, you call it MI. No, because look at the EKG doesn't look like that way. And you can do troponin, and the troponin will be perimyocarditis type small, undulating troponin, not rapid rise fall. In the past, we used to do CPKMB, which has faster kinetics. We have taken that away. Now we have to deal with the troponin, but still okay to see. And if you're in doubt, then you can do a bedside echo and see how the LV is, because arguably this is LAD, then transmural, you should see wall motion. Make sense? This, what is the diagnosis on this patient? Coming with, let's say, 55-year-old. Everybody is 55-year-old. Everybody is male. Everybody is diabetic hypertensive. This patient comes in with this EKG. What is the diagnosis?
Sir, we have to check potassium level of this patient.
Yes. And also, thank you, Tushar, you got this right away. But I will tell any younger physician that to ask, what is the clinical context, sir? Why we are looking at this EKG, how the patient presented. Patient is diabetic, patient is in lethargy, ketoacidosis, hyperkalemia. So knowledge gives you assurance and calmness. If you don't know, then you will be nervous and thinking about MI and all that, and make not yourself anxious, also the family members anxious. So what is this one?
Why not potassium, sir?
It is hyperkalemia.
Yes.
Absolutely.
Possibly hyperkalemia. Yeah, sir.
Yes. And Tushar got it right because he's more experienced. But I'm saying if you cannot get this right away, then ask yourself, how is the patient presenting? Lethargy. And then diabetes, hypertension, clinical history. Talk to the patient, talk to the family, find out how the patient presenting, and then correlate with the EKG rather than getting anxious. And yes, you can task the patient, examine the patient, and try, if you can have the access to the ultrasound, you can do the ultrasound as well. But this should be a pattern. This pattern is very suggestive of hyperkalemia, and it is a non-negotiable. If you get this wrong in cardiology board, you fail. It doesn't matter how genius you are in the clinical section. EKG section, you cannot score pass mark, you fail the whole board. It's very important. How about this one? Inferior ST segment, some ST changes, T wave upright V1, V2, and R predominant. Before calling it inferior posterior, make a habit that how the patient presented. What is happening at the bedside? Is the patient hypotensive? Are we dealing with an RV infarct? It's very important because that will determine the course of the patient. This patient came in with uncontrolled hypertension, not feeling well in the emergency room. They called you a STEMI. What you do?
It's not STEMI.
55-year-old diabetic hypertensive.
Look at the QT test here.
So this is LVH related. Remember the voltage criteria, whatever criteria you Sokolos or the Rom Hills STs criteria or voltage criteria. But I tell my fellows there is Ahsan sign, which is this V2 and V3 touching each other, the S and R. When you see that is LVH. And this LVH means it is LVH related STs. And look at this, there is no changes in the repolarization part. It is unlikely to be a STEMI. And then you can do a quick echo and LV function normal, even hyperdynamic. You don't need to go to the cath lab. And please do not give lytics. And what is the diagnosis on this one?
Hafiz bhai.
Yeah.
Ageta kintu QT kintu short.
Yes, it can happen. Because, do you know why? Wadud?
Hello, QT kintu
Yeah, do you know why?
Yeah.
I tell you, this is a very astute observation by Professor Wadud Chowdhury. The patient also had hypercalcemia.
Yes.
Okay, so hypocalcemia, hypomagnesemia can give you long QT, but hypercalcemia can give short QT. Usually, if you correct it less than 360. What about this one? ST segment depression in the precordial lead, R dominant, T wave upright, isolated posterior. And this PVC is also to be noticed. And this one is precordial ST segment elevation and distinct Q waves, coming with feeling unwell and shortness of breath for last 1 week. Patient had previous cabbage.
LV aneurysm.
LV aneurysm. This patient has paced rhythm. We cannot do anything. Tough luck. You know, some people say, if you have a paced rhythm from before, and that EKG is different than this EKG, you can say maybe ischemia infarct playing a role. Or you can use Garbosa for paced rhythm, but it is not well studied and we can't say. However, saying that this left bundle sinus stack EKG, patient is having chest pain 10 out of 10, diaphoretic, blood pressure systolic 95. You get it? What is happening?
LVV with STEMI.
Yes, exactly. Because I gave you enough clue. And if you look at the Garbosa, it meets almost 3 of them. So this is real. And left bundle and left axis deviation, sometimes we see this. I don't know, Atahar bhai, what will be your comment, but this is extensive conduction system disease. Clinical context is the only way to go. Yeah. And then right bundle, you can still read it. Right bundle, you can still read the STEMI. Okay, so, and then this is hyperkalemia again. And then this is Brugada, right? This is Brugada. And this ST elevation is what I call shoulder down ST elevation. Very important. You can see also in critical care unit with profound acidosis and hyperkalemia. I can give you this. More example of Brugada. There are different types, saddleback and typical type 1, all that. Pulmonary embolism we talked about. And then, okay, so let me go through. I show you another important thing, that the dot to balloon we talked about. So we really need to have a system in Dhaka city where we can institute the primary PCI early. I know many of you are doing it, but we need to have a mechanism. We can even charge the patient more money because it is need extra pay, but it is important to deliver. The lytics also important, right? If you look at the lytics dot to needle time, and therefore we need to have a nationwide STEMI protocol and a network so we can recognize and give lytics. If you give lytics very early on, the delta, the benefit, and the number needed to treat actually is much favorable than giving the lytics late on. And after 12 hours, in the latest study, we know lytics did not do much difference. So pharmacoinvasive, I told you about. The pharmacoinvasive is better than just lytics. And pharmacoinvasive, if you can institute neck and neck, almost equal with primary PCI. Now, another important thing, the localization. ST elevation in the precordial, ST depression in the precordial leads, and AVR ST elevation, and 2-3 AVF ST depressions. These patients, chest pain, short of breath for 12 hours. What is the best thing to do for this patient? Very tight, heavy chest pain going to the left arm. What to do next?
We have to exclude left pain.
Yeah,
Activate
this
cath
was
lab.
the
Activate cath lab.
Yes, you can see what we found, right? This is high risk. So the localization is important also, right? And this is a typical board question. You see the ST elevation, and then you give what you do. If you can get this patient to the cath lab, then you can give, the heparin and antiplatelets, and then transfer immediately. If the cath lab and the dot to balloon time can be less than 120 minutes, but you can give lytics and transfer immediately, pharmacoinvasive, if you don't have the cath lab within 2 hours. Everything else is wrong answer. Hypothermia sometimes can confound the problem, but hypothermic patient had drowning or cold weather. Before we give lytics, we should be careful about the known EKG changes that we see. Now, I don't know how much time we have. Localization can be problematic sometimes. This is, this white complex tachy, or this is sinus tack with ST elevations by Gemini. What do you think?
Lower panel, it shows ventricular bigemin.
Yes. And this is the problem. And in this case, it is a bigger problem because it is very rare, but you can have two culprit arteries. And in that case, you need to choose. And everyone, particularly interventionists, to remember the conduction system blood supply, because SA node is much more protected than the AV node. AV node gets supply from the 90% from the RCA. And also remember the extensive conduction system is left bundle with the proximal LAD. So in this case, we took care of the RCA first, and then we did this LAD as well. But anyway, so it is important that we recognize the EKG and sometimes not be fooled about the infarct-related artery. What about right bundle? Right bundle, we can easily read the infarct-related artery, which is right bundle but inferior ST changes, right bundle with anterior ST changes, right bundle with anterior ST changes, and AFib. These are all important issues, but let me go through this. Another type of EKG changes, what we call the shark fin. These are very bad prognostic patients and sometimes can be compounded by critical care illness. Prognosis is universally bad. We have published on this, and you need to be careful about what we can do in these patients in terms of bad LV, multiple coronaries, metabolic acidosis, sometimes bowel ischemia. All these can be a confounding factor. But let me show you last cases from this morning. Because we have only a few more minutes. Okay. What about this one? 8-year-old alcoholic cirrhosis. Come in with the to the ER with the cardiac arrest. Patient was coughing blood and then lost pulses, received CPR, and then BP 65-53, heart rate 125, hemoglobin 5, platelets 59. This was the, I don't know whether, bedside echo. Oh. And this was the EKG.
EKG দেখছি না এই আসছে
Can you see it now?
Yeah.
So here there is ST elevations in the AVR. Patient is in FACC, and there is global ST segment changes, right? V4, V5, V6, right? And then lead 2, 3, AVF. So that the ER said, well, this is left main, like I showed you earlier, another patient, right? And they're saying you should do the CAT. But you need to look at the patient. The patient has severe anemia, low platelets, and the argument should be, even if it is left main, what are you going to do with this patient? And I did not take to the cath lab, and then convincing the ER physician that look at this, the patient is hugging the ventricular walls. This is almost like hyperdynamic, right? And you need to tell the ER physician that this is the EKG suggestive of that, but profound anemia, hypoxia giving this. And that can be a mimic. So it is not recommended to do STEMI activation on the basis of that kind of left main equivalent EKG. I think it should be a dialogue among physicians and the clinical context than just giving lytics. This is very important that I wanted to make the point. Okay, 51-year-old chest pain. Father had MI at 59, this EKG. So this was, I wanted to show you this. What do you think about the infarctulated arteries?
Complex.
What?
Circumflex.
Okay. So, and anybody for RCA?
Sir, I am for RCA because it seems there is some winky backing.
Yes. Rafique bhai is not here. So forget about for interventionalist, we look at this very simply. Tachycardia, narrow complex, and then ST elevation, irregular, regular, and move to the cath lab. And I think Rafique bhai will shoot me. But this is the echo, bedside, on the way to the cath lab. What do you think? Infarctulated artery. Anyone?
It might be LAD.
Which one?
Though it's a long axis mid segment of LAD most likely, but you can see the short axis.
No. Look at the anterior wall. Anterior wall thickens. Even the apex moves. The inferior wall is problem, right?
Yep.
And also I tell you, we look at the aortic root quickly and then AI. I tell my fellows to make it a habit that the aortic root good, there is no dissection you are dealing with. Just a brainstem reflex. And then we did this cath, and funny enough, then they did this, and then they looked at this, and then happy ending. What do you think, Tushar?
Sir,
So the patient went to the floor, still having pain, and then inferior wall is down. They thought about, oh, is it acute stent thrombosis? But if you look at the EKG, it looks like circ, right? V5, V6, lead 1 AVL. Bring the patient cath lab within hours. Is RCA good? Where is the problem?
Sir.
Circ. So not knowing the EKG was the problem. So they fixed it, but we lost time. And look at that. It's a very respectable circ. So it is important to go to the cath lab knowing everything. So localization if the inferior sometimes can be problematic. So you need to look at the ECG criteria, RCA versus circumflex. Sometimes a diagonal STEMI can be present in lead 1 AVL or OM, but it is important to localize because that has significant clinical implications. They go with this criteria. Sensitivity and specificity can be a problem, but it is important to follow. Now, I'll finish because we have almost 60 minutes. 45-year-old female, just this morning came into our hospital. So I told the resident to upload. What do you think about this patient?
Chest pain. Hafiz bhai.
Try to exclude PE.
Altered mentation.
Try to exclude pulmonary embolism. Try to exclude.
Altered mentation. Pulse ox was okay. Patient is little, almost like 100 heart rate, right? So should we take the cath lab or no?
No, sir. Because the STD changes, that does not fit any particular type of MI. And the clinical context also doesn't fit her for MI activation.
Correct. And any comment on the morphology of the ST elevation?
It's, what you said, down shoulder.
Yes. Yes. These are all usually not STEMI, right? And then echo done, hyperdynamic LV. Patient came in with tricyclic antidepressant overdose. This is a 31-year-old male, another patient, found down at home. Should we call it a...
Yes, this is narrow complex regular tachycardia.
Will you call it sinus tach or will you call it AVNRT?
No, this
It
is not
looks like
sinus tachycardia.
supraventricular tachycardia. No P wave can be seen.
Yeah.
And depression in pectoral lids.
You can see some
The
retrograde P
emergency
wave if you
room
look at
This
carefully.
is also from this morning. Yeah. So this is ST depression in the precordial leads. Are we worried?
No, no, no. Actually, these are the part of this pathology that is the narrow complex tachycardia, maybe accompanied by the. This helps to distinguish between the AVN and AVR.
Exactly.
Not the coronary.
Exactly. And I will just for the younger guys in this ST segment depression should not worry you about ischemia. This is part of the changes with the AV nodal re-entry tach. And once you get this rhythm control, the ST segment disappears. May last, and you may get a troponin, but those troponin will be minor troponin. So don't get worried. So I am right on time.
Thank you, sir. Thank you for your nice presentation. And today you have made a century, because throughout the period, our participants number was more than 100.
Yes.
I think that must have
for being here.
made you happy. So before conclusion, I'd like to request Professor Abdul Chowdhury sir and Abdul Jamil sir to give their comments. Abdul Jamil sir.
Yes.
Your comments on the presentation.
There's nothing to be mentioned about the presentation. Always Hafiz Bhai's lecture is excellent. And I learned few things from this lecture also. And every time I learn from his lectures. And excellent for localization of STEMI. And it is very important for the interventionalist beforehand going for the cath lab. If we can appreciate that which artery is involved, that helps us to go quicker intervention in primary PCI. And mimicking ST is also very important, and it was nicely demonstrated by Hafiz Bhai, and that alleviates our confusion with other than MI patients. Thank you so much.
I wanted to apologize about that. I was very fast today because I wanted to cover many things. And I really think that this is a very learned audience. So I can afford to go fast. That's why I was
Hafiz Bhai, can I share
Yeah.
one very fatal complication?
Yeah.
If you
What's
permit
that?
me. I just want to
What's
share
that?
one finding, if you
Yeah.
permit me.
Yeah.
Can I share something?
Sure,
Yeah.
sure.
I don't know. Is it coming?
No, no.
Not yet.
So much white screen is coming.
Yeah. How can I share this one?
Go to
Abdul
share
bhai,
screen.
Sir, you are
Abdul bhai,
sharing
please help.
whiteboard. It's not a screen, it's whiteboard.
Yeah, I wanted to share this one. Is it coming?
Go to the
Share it
lower
again.
panel of the share screen.
Sorry. Yeah, share
Green
screen.
button is the green upper arrow at the bottom.
Okay. Okay, I'll share.
Click it. Then you can,
Yeah, okay.
yeah.
So this was 49 years male, came with 4 hours of severe chest pain. I mean, patient was hemodynamically stable. So any comment on this EKG? This is 4 hours chest pain, patient hemodynamically stable, severe chest pain in the emergency.
Yes.
There's some
There's a-
biphasic T wave in V1, V2, Wellen types.
So
Discomfort.
what do you want to do in this patient? Take to cath lab,
And the chest pain started in
4 hours chest pain.
4 hours chest pain, right? It didn't stop at all.
Did you do tropide?
Oh,
Tropide?
that tropide takes time. They take around 1 hour in our setting.
Mm.
So Hafiz bhai, what we should do? Is he
So
here?
it's all depends on the clinical context, right? The
Mhm.
Severe chest
EKG
pain.
as biphasic, right? And then chest
Yeah.
pain is typical. The troponin is positive. Echo is,
The troponin is not
Good.
done yet.
No, not
Probably not done.
and what is
No,
the
it's-
comorbidity of the patient?
no
Who
risk
is the
factor.
patient?
No risk factor. 49 years.
Any
49 years.
echo available there?
Yeah, did an echo. I mean, everything was clear. Some degree of hypokinesia, which is not recorded.
Mm.
cannot
So
show
I
you.
think you mentioned about the fatal complications. So the faculty, we all are worried, but probably you did the cath and there is indication to go to the cath lab
Okay.
because
Okay,
the
sure.
chest pain is classic. It
Mhm.
is looking like LAD, most likely.
So we-
and
so-
therefore probably will to go to the cath lab.
Yeah. So I did do, one of my colleagues did. So we
Mhm.
took him to the cath. This is a picture of the patient.
Mhm.
So what do you think of lesion in LAD? There's always question of vulnerable plaques and all.
LAD lesion is not much significant.
Critical. Only
So-
did you have dissection there? I don't know, later
Yeah.
on.
No, just
What's
thought.
that?
So anything you should do in this patient?
No.
So we all are convinced this patient needs cats, right?
Mhm.
So did nothing. And how should I treat? That's the question. And then 1 hour later, patient develops numbness, weakness of both lower limbs. He had paraparesis and
Ah,
developed paraplegia. Sorry, this is a CT scan of the patient. What you can see here is a long
mhm.
dissection here.
Yeah.
From
Eh,
left
yeah.
subclavian artery down before the bifurcation involving just before bifurcations.
So what about the ascending aorta?
No, ascending aorta is fine.
It's
This,
type B.
Yeah, type B. So this patient, I mean, we don't have a neurosurgical service. We send patient to other center, and
Mm.
now I get the information he's almost brain dead.
So I have a question
Yeah.
that I asked this earlier also. Did you do an echo before
Yeah.
taking to the cath lab?
Yeah, ascending aorta was totally free.
Was good,
Yeah, good. Nothing with
and
the
then no wall motion.
some degree of wall motion, but that's very difficult to say. It's just a quick
So-
screening.
So this is so and the coronary angiogram looked okay, right?
Yeah, this is a angiogram.
And the blood pressure was okay, right?
Yeah, hemodynamically stable.
So is it a descending dissection from the get-go and EKG was non-specific?
Yeah.
Or is it a complication of the cap?
No, we did from right radial axis.
So it is not a complication of the cap.
No,
And
It's
also,
not complication.
usually we don't see a complicated retrograde dissection this time. So that is out. So this is a descending dissection to start with.
Yeah.
And I have one question. The patient had a migrating type of chest pain, like it started like in the mid part, then went down, started in the neck, it went down.
Asking the patient, he says, "Oh, I have some discomfort in the back, but not that typical finding."
Because
So-
normally this type of dissection has some migration of the pain from the neck
And
back down in the back area and going down.
It's type of
so
tearing type
let
of-
me tell you something, because we have a lot of people in this discussion to hear. There are 5 things of chest pain in the ER. One is acute MI, dissection, pulmonary embolism, pneumothorax, esophageal rupture. These are the 5 biggies. And if you look at this pneumothorax and esophageal rupture, it's very easy to discard. The pulmonary embolism, dissection, and acute MI difficult. But if the EKG shows ST elevation, it has to be ascending dissection. If the PE, severe hypoxia, other features, echo may help, right? But the dissection, descending dissection, and acute MI sometimes can be, this like your case, is a problem, and there is no ST elevation. Some T wave inversions is basically what we have. And in that case, echo did not help. Does it help with the uncontrolled blood pressure, checking pulse and blood pressure unequal on both sides, back pain, any clue that may be helpful? But
Now,
it is
my another
unfortunate that it sometimes fools us.
Yeah, my another question is right now, whether he's weak in the arms also or only in the legs. I missed that part. He's paraplegic, but
he was referred to the hospital because we don't have. I work in a dedicated cardiac hospital. They did some bypass in the carotids because they had some problem. So I don't have too much of details.
no, yeah, the
but-
very specific question on exam should be, as Dr. Chowdhury mentioned, whether it's pulse and difference in both arms. That means ascending is involved, part of the ascending at least.
No, it's not. It's the dissection is just below the left subclavian artery.
That's a descending. That's the question right now. If it's a descending artery involved,
You can
the
have
pain
radiofemoral delay, pulses problem in the leg. And
yes,
the other thing is that it's sometimes difficult. It depends on your threshold of the clinical, that. And another thing I wanted to ask you was the troponin, because this troponin will be very small troponin
So I'll have to,
if it is
because-
positive.
Well,
Asif sir.
after an hour, we did this after CT was done, he was immediately transferred. So I'll have to check that.
I got it. Yeah.
Professor Hassan sir, can I supplement something?
Yeah.
Actually, regarding this ECG, is it rational to start STEMI activation, emergent PCI, whether in this case, in emergency department, there's a non-specific STD changes, why not CT to rule out, triple rule out in that case, as there is a back pain is more than chest pain. So CT can rule out both dissection as well as pulmonary embolism in that case, I think.
Yeah.
He did not
So-
give any history of back pain when he attended emergency. He said, I have severe chest pain. And later, when we suspected, we did a CT, we tried to get history. He said, yeah, some degree of back pain too, but not that typical.
To answer your question, let me tell you, this EKG does not fulfill the criteria for a STEMI, right? Does not. The chest pain makes you worried. EKG makes you worried. But even if you have know if you are in a remote area, where will you give the lytics on this EKG? No, because it
No.
does not fulfill the criteria.
No.
Right? So that is first question. Second question is, if you do have the pain suggestive of, dissection, the back pain, shoulder pain in between shoulders, the concept of triple rule out is very good, but we published with Dr. Matt Budoff. He's the chair of the CT board for the coronary angiography, CT angiogram and training requirement, Matt Budoff from UCLA. It is a very attractive proposition to triple rule out PE and coronary and also the dissection. However, in the US, it is practically impossible because the radiologists are not comfortable to read the CT angio, and the cardiologists are not comfortable to read the PE with this. So it is not really a good proposition. And the other thing is that we are afraid about the protocol and the radiation dose. But maybe one day, but I think we should be, vast majority of the cases at the current time, we should be able to figure out with a sense of clinical suspicion, EKG, bedside ultrasound, but still in a rare case like this, we may miss it.
Thank you. So, I mean, I don't know, this patient was not thoroughly examined. Had it been examined, the low limb pulses, then that I think some clue might have been there.
Yes, exactly. Exactly. And the patient, I don't know that nowadays fellows do not check the pulses because radial is good, they are good. But it is important to do a thorough exam.
Sir,
Thank you.
Thank you, sir.
Can I, Tushar bhai?
I think it's 10, almost close to 11.
Sir, bhai,
PM.
can I take the floor for 1 minute?
Yes, just one question, please.
2 questions. I have 2 queries, in fact.
Go ahead.
Firstly, I would like to
Yes,
thank Arun sir, because he always comes up with very interesting cases. 1 or 2 cases, but excellent. It was an excellent learning for me. And to Hafiz sir, I have 2 queries. Like before, we used to say that a new onset LBBB, but these days, the question is being raised that when do you call an LBBB a new onset LBBB? Is there any defined landmark? I mean, the time cutoff, like whether it should be 1 day or 1 month or 6 months or 3 months.
Yeah, we see this all the time. New to who? Most important is that they're new to the patient, not new to the physician. Patient may not have EKG before. Some people are now doing this, particularly cardiomyopathy patients, they have their EKG stored with them and they can show you the EKG. But that's rare. Most of the important time is that the left bundle is new to the patient or not. Second thing, try to look at the old records in the hospital. Talk to the patient. Say that sometimes they know that they have this old left bundle. And important thing is that if it is MI, is it behaving like an MI? That is more important than finding the left bundle. And then try to see whether you can use the Garboso criteria to make a decision. And then use the bedside imaging, like bedside echo, to figure out what to do next.
In US and UK, you have hospital records, but we don't usually have any hospital records. So it is these days being said that it's better not to call a new onset LBBB because you don't exactly know which one is a new onset. The next question is, like you have said,
I think
that
another important point I'd like to make in this case, definitely clinical history and echo could be very helpful, bedside echo.
Yes, yes. Clinical. The presentation. If the patient is having, hoo-ha, chest pain and atypical, one thing. But remember another important thing, and we need to use our common sense. Somebody coming with left bundle, patient is hypotensive, shock, diaphoretic, something catastrophe happening. That left bundle is more important, old and new, is than anything else. So clinical is more important. Patient is stable, rock stable, but sweaty, diaphoretic, 10 out of 10 chest pain. You have no other cause to explain. Think about it.
Sir, but if I'm not wrong, LBBB in the setting of anterior wall MI is very, very rare, as we know that the posterior fascicle of the left bundle branch has a dual blood supply. So it's not that common in the setting of anterior MI.
Correct. And this is the reason, as you pointed out,
Yes. And
it is
second
not a
question is, sir,
automatic
like you,
activation. We should
you
not
have-
activate automatically.
yes, like you have shared pulmonary embolism ECG, and there you have shown that there is a widespread ST elevation, and it
Yes.
only occurs in the setting of a large thrombus. I mean a massive pulmonary embolism. And the clue you said is tachycardia, and the other one is disproportionate hypoxia. But if it's anterior MI, extensive anterior MI, we can have sinus tachycardia. The only point there I think it's very valuable is disproportionate hypoxia, because tachycardia we can get even in extensive anterior, and it suggests a bad prognosis that the patient has impending left ventricular failure.
And to add to that, your clinical exam in the PE versus left ventricular, think about this. If it is extensive anterior, patient is shock or impending shock, left hypoxia will be due to LV failure. And you should have some congestion in sign, S3, fine crackles, lungs congested.
Yes,
You will
sir.
not have a clear lungs.
Yes, sir. Yes, sir. It was an excellent lecture from
Chowdhury.
you as usual, sir. And thank you very much.
Wadud,
But
sir.
you were too fast today,
I
I
sir.
want to ask a question.
we,
Sir,
Wadud,
I
sir.
want
we have to finish within minutes.
Yes.
sir, I want to ask a question. The inferior MI with the infralateral MI, in that case, which one was the infiltrated artery? Was it diagonal or LCX? I couldn't understand seeing the CG.
What?
That was a lead
What?
1 AVL ST depression, and there was ST elevation in V5, V6. But they found a lesion in the RCA. They went after the RCA first. And within hours, they had to bring the patient back because the infraclated artery was left circumflex. And sometimes when you don't look at the EKG carefully, you may miss the infraclated artery. And remember, a 95% stenosis with good T3 flow may be more common with lytics and pharmacoinvasive strategy. But for primary PCI, with the transmural MI picture, the flow in the infraclated artery is slow. You hardly get T3 flow in an infraclated artery unless lytics have been given.
Thank you.
Tushar.
Wadud, sir. Wadud,
Yeah,
sir, I'm requesting you to conclude the session as we are almost close to 11 p.m.
আমি বাংলায় বলি। আজকে আমাদের এখানে যে আছে অরুণ, ও কিন্তু বাংলা খুব চমৎকার বলে, কাজেই ওকে ইনক্লুড ধরে নিচ্ছি যে আমার বন্ধুকে, যে বাংলা ভাষী একজন। অনেকদিন পরে আবার সবাই একসাথে এলাম, এটা খুব আনন্দের ব্যাপার। এই গ্যাপটা আমাদের খুব পছন্দের ছিল না, কিন্তু হয়ে গেছিল। আমরা আশা করছি এবং প্রমিস করছি এরকম গ্যাপ আশা করি আর হবে না, এবং সামনে আমাদের ইসিজি ঝুলিতে আরো চমৎকার সব নতুন নতুন জিনিস নিয়ে আসবো আমরা, এবং সেটা কিছু থাকবে খুব সিম্পল জিনিস যে একটু জুনিয়রদের জন্য একাডেমিক, আর কিছু থাকবে মাইন্ড বগলিং থিংস, যে যেমন অরুণ মাসকে যে একটা কঠিন একটা সিচুয়েশন দেখালো সেরকমটি। এই দুটো মিলে আমরা আশা করব যে আমাদের এই প্রোগ্রামগুলো আবারও অ্যাট্রাকশন করবে সবাইকে। এবং আতার ভাই এরপরে নেক্সট প্রোগ্রাম কবে করবেন সেটা ডেটটা কি এখন বলে দিবেন?
জি অদূত ভাই, আমাদের নেক্সট এইচএসি প্রোগ্রাম হচ্ছে যে জুন 9, দ্যাট ইজ সামনের মাসের 9 তারিখে, সেকেন্ড সানডে, এবং সেই দিন আমাদের প্রেজেন্টার হবেন আমাদের ডক্টর আজিজ ভাই ফ্রম ইউএসএ।
ইনশাল্লাহ। আমার মনে হয় হাফিজ ভাই, as always, you have been a source of inspiration as well as for sheer enjoyment. And we are really happy that we got all the familiar faces in front of us. And that's really encouraging for all those who have been involved all these years for this improvement, entanglement, and entertainment through ECG discourse on ECG. Thank you, everybody, and good night.
And
আমি
next time I'll be next time I'll be slow.
আমি অবশ্যই ধন্যবাদ দিতে হবে, বিশেষ করে কামরুলের কথা না বললেই নয়।
আর Wadud, আমি next time slow যাবো।
ইনশাল্লাহ।
ইনশাল্লাহ।
আমার তো মনে হচ্ছিল আজকেরটা 2 কোর্স করে 2 পার্টে করে দিলে পরে আরো ভালো হতো।
ঠিক।
আজিজ ভাই, আপনি কবে কি করবেন সেটা একটু জানান, আপনি কিসের উপর বলতে চান? আমরা তো
আচ্ছা, I think Dr. Atahar just requested me on the phone and I'm okay to do it. আমার একটা ক্লিনিক আছে, ওই দিন আমি ফ্রি ক্লিনিক করি, কিন্তু আমি ক্লিনিকের পরে আমি হয়তো হাফ অ্যান আওয়ার ক্লিনিকটা আগে আমি সরে যাব। I can attend, I can give the lecture. হ্যাঁ, এটা করতে পারে কি? আমার প্রশ্ন হচ্ছে কি, আমার কয়েকটা প্রশ্ন ছিল, যেটা যে আমাদের অডিয়েন্সটা কারা, বুঝছেন ব্যাপারটা? হ্যাঁ, সেই হিসাবে তো একটা লেকচার তৈরি করি আমি। তা
স্যার আমাদের
আমাদের
এখানে
যদি হ্যাঁ
আমাদের এই প্ল্যাটফর্মে along with cardiologists there are medicine trainees, doctors who works in different specialties also, so it's a mixture of pure cardiologists as well as many other specialties.
এখন জিনিসটা হচ্ছে কি, আমি তো মোর ক্লিনিশিয়ান, তো হ্যাঁ, আমি ক্লিনিক্যাল কার্ডিওলজিস্ট, এবং
আজিজ
আমার
ভাই,
একটা
আপনি কিন্তু যে ক্লিনিক্যাল সিনারিওর সাথে একদম
হ্যাঁ।
বেসিক গুলো দেখলে আমি বড় বেশি খুশি হব। কারণ আমাদের কিন্তু ঘুরে ফিরে ওই জায়গাগুলোতে বেশি আসতে হবে।
আসতে হবে, আমি সেটাই প্রশ্ন করছি।
ইপির জন্য যে ইসিজি গুলো দরকার, যে ডিসকোর্স হয়, সেটা কিন্তু আমাদের এই ফোরাম তার জন্য উপযুক্ত জায়গা নয়, কারণ ওটা আরো কঠিন, আরো ডেপথে যাওয়ার জিনিস। কিন্তু এখানে যেমন আজকে হাফিজ ভাই যে কত রকম ইসিজি মিমিক দেখালেন, বিভিন্ন সিচুয়েশনে ইসিজি গুলো কি চেঞ্জ হয়ে দেখালেন, এই ধরনের ডিসকোর্স গুলো বরং অল্প অল্প করে বলি, কিন্তু একটা ফোকাসড ওয়েতে একটু ডিটেইলে বললে পরে সবার জন্য ক্লিনিক্যাল সিনারিওর সাথে
আমি এক কাজ করি, আমি যেমন আমি টিওএ অ্যাবনরমালিটির উপর বলতে পারি, ক্লিনিক্যাল সিনারিও। হ্যাঁ,
জি বলেন।
টিওএ অ্যাবনরমালিটি, ক্লিনিক্যাল সিনারিও,
স্যার কারণ
হ্যাঁ,
আমাদের
কেস সিনারিও দিয়ে আমি করতে পারি আর কি। হ্যাঁ,
জি স্যার,
ঠিক আছে।
উদ্দেশ্যটা হচ্ছে যে আমাদের যারা সবাই বুঝতে পারে এবং সবাই পার্টিসিপেট করতে পারে।
আর আমি অন্যরা অডিয়েন্স যারা আছে তাদের সবাইকে বলছি, আপনারা যদি কোনো কিছুর উপর নিজে প্রেজেন্ট করতে চান, যেমন আজকে অরুণ যেটা করলেন, যে অল্প একটু সময় নিলেন কিন্তু চমৎকার একটা ইন্টারেস্টিং জিনিস দেখালেন, এরকম 5 মিনিটের প্রেজেন্টেশন। আমি সাইলেন্ট ওয়াচার দেখতে পাচ্ছি নাসির ভাইকে, আজমকে, এবং আরো অনেককে, ফাদিয়া আফরোজকে দেখতে পাচ্ছি, অজয় তো সবসময় মুখর, এরকম অনেককে দেখতে পাচ্ছি। আশা করি তারাও শরীক হবেন। হ্যাঁ, আমি এটাই বললাম, আমার খুব ভালো লাগছে যে তোমাদের নামগুলো দেখে, খুবই ভালো লাগছে। থ্যাংক ইউ সবাইকে। বেক্সিমকে আবারও ধন্যবাদ, তারা আবারও এগিয়ে এসেছেন আমাদের সেখানে। আমি এখানে কার্ডিয়াক সার্জন হান্নান ভাইকেও দেখতে পাচ্ছি, ধন্যবাদ।
ঠিক আছে তুষার,
ঠিক আছে,
ধন্যবাদ সবাইকে। আবারও
জুনে
সবাইকে আসতে বললে আমরা তাহলে এখানে বিদায় নিচ্ছি।
ঠিক আছে, থ্যাংক ইউ,
আমন্ত্রণ।
মিটিং সারা দুনিয়ার মিটিং, বেটা আমেরিকা থেকে প্রেজেন্টেশন আছে আমাদের এই ঢাকা
বাংলাদেশ, নেপাল, আমেরিকা।
না, আমি এসছি লাইভে, কিন্তু এই